So I'd like to introduce all of you to my friend Robin Walsh. We're going to be talking about 5 surprising things you need to know about tongue and lip ties. So whether you're a parent or a professional, this is the evening that you really want to tune in, because Robin is the expert in this area, and she's already told me the 5 things she's going to be talking about, and a few of them really shocked me, and I teach on this topic. So Robin, before we get started, would you do me a favor, please, and just tell everybody a little bit about yourself and what you do? And I know you're an awesome mom, but talk to us about Robin, the SLP.
Okay, thanks so much for having me, Mel. This is great, a lot of fun. I'm a speech language pathologist, and I've been specializing in oral motor disorders, oral facial myology, oral placement. Really, since undergraduate, I became very interested in it. My aunt's a speech pathologist. She brought me to state conventions and to see Sarah. And I was really lucky at a young age to have Pam Marshala, Sarah Rosenfeld Johnson, Lori Overland, Roberta Pierce as mentors. So really, my whole career as a speech pathologist has been in this area. And I first became interested in tongue tie back in the late 90s. I do work for a public school system, and I have my own practice. And as many of you know, I work for Talk Tools as well as a consultant and author. And what was really interesting is I went into a public school. I had hoped to work in the special ed population, but they put me in regular education. And what I started noticing is all these kids who had a lisp had oral facial myofunctional challenges. And that's when I first started going to see courses, Sharp Beauchart, Pam Marshala. I took courses at the IAOM conventions. And from very early on in my career, I started talking to clinicians about screening for tongue tie. And back then we weren't talking about lip tie. We weren't talking about buccal ties in the cheeks. We were just talking about the tongue. And it kind of resurfaced a couple of years ago for me. I've been treating it the whole time, but when Lori and I wrote a sensory motor approach to feeding, and we started doing, a lot of infant research, I was surprised to find out a lot of what was happening in Brazil and in other countries and how much research was out there. And Lori and I said after the first book, we'll never write a book again. This was so stressful. And 2 years later, I'm telling her we're going to write a book on tethered oral tissue. So it's been quite a journey, but a great one. And this topic has just like exploded. And I can't even keep up with my slides for my coursework because every day, I'm adding stuff and learning new stuff and writing about new stuff. So,
well, I think that really is the crux of it, is the reason why we have 5 surprising things to share with everyone today is that we're getting new information all the time, that there's a big learning curve here. And I'm especially excited to have you talk about the first one. This is the one that surprised me the most. You were telling me a little bit about the incidence and prevalence. Can you tell us what's surprising about that now?
Yes. Well, if you do generalized research online, for example, the Mayo Clinic, that's where when Lori and I first started writing the book, one of the first things you look at is, well, what's the prevalence of this? Is it important enough to talk about, right? So generally, you'll find research anywhere from 3 to 10%. 3 to 10% of the population, because tethered oral tissue is congenital. It's something that, we can follow. What was really surprising, we start hearing, oh, is it a fad? Dr. Gahary talks about that, right, on his blog, is tongue tie a fad? How could it be, that more and more people are being diagnosed with tongue tie? One of my friends who's a physician that really doesn't believe that tethered oral tissue can cause functional problems said, well, if you have, a hammer, everything looks like a nail. So now all of a sudden everyone is seeing a tongue tie. But the key here is proper evaluation. So Dr. Marquezon, Dr. Martinelli, Dr. Barrettson Felix over in Brazil, they do amazing research. And they put into law that babies have to be evaluated for tongue tie at birth, right? So they have a lot of stats because they're evaluating every baby at birth. Right. And we've developed a special way to evaluate for tongue tie, in particular posterior tongue tie. And we'll get a little more into that because that's, a very hot topic as well. But they're making sure that you use a maneuver where you really almost like a fish hook to pull the tongue all the way back and expose those submucous type of fibers. And they looked at 1,715 babies, and it wasn't 3%. It wasn't 10%. It was 32.54% of these infants had a posterior restriction. Mm-hmm. So, we're talking 10 times more than what is being, published in the mainstream research. And of course, once you know how to see something, you can't unsee it. Right. So it's almost impossible to ignore, once you have a feel for being able to do a proper tongue tie assessment, lip tie, buccal tie. And, I think about some of the kids that I saw 20 years ago, and I was checking everyone for tongue tie, but I was looking for this classic heart-shaped presentation, anterior restriction. I had no idea. And back then, we didn't have that information. We didn't have Kotlow's 4 classes of tongue tie and Carrillos and Jenna, the 5 types of tongue tie, where we really knew what was happening with that. So it's really, really important that we do that proper assessment.
You're making me think about, too, I don't even know how long ago. I think it was maybe 17 years ago, 18 years ago, I used to work in the NICU. And I was taught just what everybody else was taught, which is if the baby can stick their tongue past their lower lip, they don't have a tie. And everyone knows that's a myth nowadays. But also, we were going off the information provided by the American Academy of Pediatrics, because in 2004, they had a statement that said that the highest incidence of the highest prevalence of the type of tongue tie, and they range from type 1 to type 4, is type 1, which is that very anterior, you can't miss it, ankylosing. And my question is, wait a second, is it really the most common, or is it just the one you can't help but notice? Because nobody was looking for that posterior.
Yeah, definitely. Absolutely.
Yeah. And then the other thing that I learned, which is really a big myth, is I learned way back then that we'll be able to stretch it. And that's another surprising fact.
That's surprising fact number 2.
Yeah.
So I admit, when I first started teaching my SMILE program, which is a myofunctional program for lists, I used to talk about my mentor, Sarah Rosenfeld Johnson. She had something out in Advanced Magazine about how to stretch a frenulum. And basically, we used to talk about using our bite block tool and starting at the midline, touching the tongue tip to the tool, then moving it to the canine, and then to the premolar, and then to the molar, to get the tongue to move further and further back for that lateralization that you need for chewing and maintaining a lateral chew, things of that nature. But again, leaders from Brazil, our friends Dr. Martinelli, Marquezon et al., they really changed things when they started looking at the actual tissue of the frenulum. So in 2014, they wrote about the histological characteristics of a frenulum. And I printed some research out, and this I want to read because I just want to get it perfect because it's so fascinating. But it talks about the altered human frenulum, and that it's striated needed skeletal muscle fibers, high frequency, or type 1 collagen in deep layers and compact bundles of elastic fiber positioned near the epithelial lining. So what this tells us, we know something about collagen, right? We all want it in our face because it keeps our wrinkles away, right?
Right. I love collagen.
Oh, collagen's awesome. And we have collagen in our heart, makes our heart strong, keep it ticking. Well, we can't stretch that tissue. So now that we have more information, but Sarah wasn't wrong, and I'll tell you why. The key word here is fascia, okay? The fascial fibers surrounding that collagen. And I do believe what we were seeing, because I still see it in therapy today, that when we work with a tongue-tied patient or a lip-tied patient, and we're working on techniques like using Beckman stretching, and we're using a sensory motor approach to feeding, and we're going through oral motor interventions, what we're really doing is we're releasing that fascial restriction that's surrounding the frenulum, the collagen. And, we can see some gain in range of motion by doing that. Now, what came out after this landmark study recently, Mills et al. Have also been studying the makeup of the frena, and they actually dissected the frena of cadavers in both adults and in babies. And I'm going to read you a little bit about this, because this is also very fascinating. So what they said is that while many call the frena a cord or a submucosal band, there's no evidence to support it. They stated that the lingual frenulum is a dynamic structure formed by fascia fusing with connective tissue on the tongue's ventral surface. The sublingual glands and submandibular ducts are enveloped by the fascial layer, and lingual nerve branches are located superficially on the ventral surface of the tongue, immediately into the fascia. So we've been really talking about for some time, trying to convince others about the existence and prevalence of the posterior tongue tie, right? So Mills and company come in, and now they're arguing, well, this isn't really posterior tongue tie. It's this intertwined, mix of the tissue. And but basically what they're trying to say is you can't go in and just clip this or dissect it or not consider that these nerves are sitting underneath this tissue and that the muscle is also intertwined.
Right. It's literally just simplified. It's just all connected.
Yes, it's all connected, and you can't just, randomly go in there and release it. So it's kind of like tomato. I think essentially these studies are really saying a lot of the same things. One, that we can't just go in there and stretch this or correct it with therapy by itself. We can't just go in there and randomly, have at it with surgery, because there's a lot of different fibers intertwining there, and we have to understand them. But, these studies on the cadavers weren't large case sample studies. And my question is, not being a scientist or a doctor in that end of it, when you're working on a cadaver, does it change the tissue at all in terms of, could it be more stiff? Or is there a breakdown? Like, how long after post-mortem was this performed? And, how did they know the patients had tongue tie to begin with? So very, very interesting. And I've spoken to a lot of, chatted with a lot of the very well-known surgeons. And when I get this research, I always inbox them. I'll ask Dr. Gahary, I'll ask Dr. Siegel, Dr. Yan, what do you think of this? And what's your interpretation of this research? Dr. Baxter, another one I like to email, because I want to hear from the medical end of this. What does this mean for me as a therapist? And the main thing, which was point number 2, can't stretch it. But what you can do is help with the fascial restrictions that surround the frena.
Exactly. And getting back, and I'm sharing this because I think there are pediatricians out there who are trying to learn about this. And just
Yes.
like you and I discussed, things are changing. We didn't have the greatest information 20 years ago. We're
No.
all constantly learning. And just jumping back to that 2004 statement from the AAP, one of the words that they use is that it's elastic, that the front is elastic. And it's not. It's
No.
not. But I remember thinking it was based on that statement. So since we're talking a little bit about how things change, one of the things I want to share with everyone who's listening tonight is just the fact that I really believe that you and Lori are the premier source for helping all of us to understand the importance of that functional assessment and some pre-op exercises. I'm just wondering if you can share some surprising tips about that.
Okay, so my number 3 surprising fact is that everyone should have a functional assessment prior to surgery. And I think as therapists, people are probably saying that are hanging out with us tonight, listening to us. Well, Robin, that's not surprising. We know that. But
Right.
it is very surprising to a lot of physicians or to those who aren't really knee deep in oral motor therapy and feeding therapy. So I want to talk about, there was recently a study in JAMA, and it was by Callaway et al., and it upset a lot of people. So what was this study about? Well, the study, I feel was kind of misinterpreted by the main media, because they talked about how they avoided surgery in supposed tongue tie cases, and that 63% of the breastfeeding infants were saved from, having a release. And I took this study in a little bit of a different way.
Yeah.
First of all, nearly 40% still needed a procedure, okay?
Yeah.
And what was special about this study and what drove it home for me is that what they were trying to say is the cases were referred to a surgeon at the hospital, right? So the surgeon actually admitted, like, I was getting these referrals. Practitioners felt that they were having feeding issues from tongue tie, and I did the surgery. And again, going back to incidence and prevalence, the numbers were going up so quickly, said, stop, we have to make a better protocol for this. And they tried. Most of the referrals came in from lactation. And then they put together a team, the speech pathologists, who were also CLCs, and that wasn't listed in the study. They were certified lactation counselors. And, we do know that the IBCLC is the gold standard when it comes to breastfeeding. But they did have breastfeeding experience, which some, were criticizing that, it was just SLPs, where was lactation? But lactation did the initial assessment, then they sent to speech. And what it was, they were able to weed out in these functional assessments who may have had, because I emailed back and forth with the speech therapist that wrote this study, they were looking for, was it an oral dysphagia? Was there hypertonia, hypotonia? And some of these babies were not tongue-tied at all. That's why it's so important to have that pre-op functional assessment, because, it isn't easy until you have a lot of experience to be able to really look at what might be a submucous or a posterior tie, right?
And also because you're not just looking for the tie and how that might be impacting function. You're looking at all the other stuff in the weeds too. Like, well, because in my experience, it's rarely just the tie. There's usually 10% of this, there's a little low tone, there's usually this or that. And then you have to have the experience to really try to figure out, well, how much of everything else is influencing the function itself. Am I making sense here? To me, it's just like one big oral salad. I'm like, which is the most important thing here? Especially for our children who have severe disabilities as well.
Yes.
That's really, really tricky. And that's where the experience comes in. And again, we're just always learning. But I know you also talk about post-op being just as important. Tell me a little bit more about that.
Well, yes, we this is our, fourth really important fact is that, pre and post-op are equal. Okay. So when you talk about, and I'm kind of putting these two things together, Mel, when you talk about a pre-op functional assessment, but then pre-op therapy, what are the goals of pre-op therapy? I call them the 3 C's. The first one, and Lori had a lot of input in this, of course, the first C is the client. We want them to become acclimated. You could throw, a lot of things in here, children on the spectrum, children with sensory integration disorders, and just neurotypical children that don't want you in their mouth, I personally, I love all my dental friends and my RDH friends. I'm not a fan of going to the dentist. So the mouth is a very private, sensitive area. So with that being said, the first C for the client, you are getting them acclimated to what needs to be done, right, after surgery. And you're also helping them maximize their best potential range of motion with that neuromuscular and the fascia, right? Then the second C is the caregivers. I mean, imagine being a mom of a newborn baby or a child with special needs. And I got 3 calls today. Help, I just had a release and my kid's freaking out and I need to see you immediately to learn how to do these stretches. It's like, I have no baseline. The parents are freaking out. That pre-op therapy allows you in calm, no pain, repetitive, times of trial to train the parents, the nanny, the grandparents, whoever's going to be involved in that aftercare, to learn exactly what needs to be done. And then finally, and then finally, the third C is us, the clinician, because when a patient comes in, especially for, therapists working in a school, working in a hospital, where you're not in a private practice and you just can't say, well, I'm going to take 2-3 hours to work with this family, and you're, locked in to maybe a 30-minute eval or a 60-minute eval. You can't get all the information you need sometimes. The child could be crying. Maybe you need to see them eat and they're not hungry or they don't want to eat with you. So that pre-op baseline is so important. And what we're doing in pre-op is exactly what we're going to do in post-op, which is use sensory motor integration. Okay, we're going to map sensory onto motor. That's Lori's, big shtick. She always talks about it. And, we're going to work with a team. We may need an OT, a PT, lactation, the concept of body workers. When I first started, lecturing about this class, I was in New York. Scott Siegel put together a symposium, and I met Michelle Emanuel, who really taught me the concept about body work in relation to TOTS. And Lori and I have really been pressing this in our classes, that what you see in the body is what you get in the mouth. With TOTS, what you see in the mouth is what you get in the body.
So true.
Yeah, you really need to be well versed. For example, in our class, I always talk about a baby that came into me, and you think about a 6-month-old baby. What are the things that make them happy? Being nurtured, being loved, being fed, being comforted. And when you see a baby come into your office and that bottle approaches the mouth and they go into flexion, the hands were clenched, the little feet were up in the air. The first thing I want this baby to do is go get some body work. Go for the OT or PT consult, craniosacral therapy. So it all ties in together. It gets complicated because when we talk about that post-op care and prepping and pre-op, Lori and I both feel, there's really 2 stages to post-op care. The first is the active wound management, and that's being scripted by the doctor. Right. And as a speech pathologist, I feel I can assist with that, with the sensory motor, with helping the child acclimate. but we don't really have those words, Mel, active wound management in our scope of practice. So speech paths have to be really careful with that, where OT and PT, that's actually part of their accrediting scope.
Right.
So that's why we all need to work together. So there's that active wound management that comes from the physician. And unfortunately, a lot of the laser specialists are giving things to do at home. A lot of the ENTs that are using sutures are not, and we really need to educate in that area. Because it doesn't matter, if it's a laser or scissor release, you have to do that aftercare. You have to do that neuromuscular re-education.
Well, so that's really our fifth point here.
Yeah.
In my courses, when I do a 2-hour module on tethered oral tissues in my 2-day course, and I always, every single time, get the question, which is better, laser or scissors? So can you answer that for everyone?
Well, if you've read Lori and I's book, you know that we had both an ENT and an oral surgeon, one being an expert in Z-plasty, scissor releases, and one being an expert in CO2 laser releases. And I work with both their patients quite often, in addition to other local providers that I've really got on board with this over the years. And I'm going to say that it's not the procedure, it's the skill of the surgeon. Yeah. I know I've done some work being a guest lecturer for the American Laser Study Club, and I did take a class to learn more about the different lasers. And I do know there's some research there that the CO2 lasers are preferred. And if you look at all of the very well-known laser surgeons, many of them are using light scalpel, and they're really supportive of that CO2 model. But there's a lot to consider when you evaluate a patient. I always give the options, and there's pros and cons to both, and we cover some of this in the book and when we teach. But of course, with the laser, not having to have the need for general anesthesia if it's not necessary is great. It's very quick. It's essentially bloodless. A lot of, I know I went to Dr. Siegel's office to observe him. He does allow the parents to stay in the room. Some do, some don't. Right. But it's quick. And for many parents and for many patients, this is a better option. They feel avoiding anesthesia and doing it this way. Then, as you mentioned, there's a lot more that goes on, right? So I have a lot of patients that have airway issues. They need tubes in their ears. They might need their tonsils or adenoids out, or they have special needs. And, parents would prefer that not only they be under anesthesia for the procedure, but they would prefer it maybe in a hospital or a surgical center, and they want stitches. They want those stitches there because it is both need aftercare and neuromuscular re-education, but the laser procedure, in keeping that diamond open and making sure it doesn't scar down and it heals properly, is definitely more difficult with some of our special needs populations. But you can also do a laser procedure if it's tolerated and have stitches put in. Dr. Siegel and some of my other providers will do that if we feel it's going to be a problem tolerating the aftercare. Certainly in an infant, it's going to be more difficult. And many of the oral surgeons also have the ability to use various forms of anesthesia if necessary. There was just a talk about this in one of the Facebook groups, and a lot of the surgical providers were chiming in about that you can use a laser and do sutures. So you don't necessarily have to choose a scissor release just because you want the stitches. So it's really a lot of factors: insurance, travel, finances, the the ability to do the therapy after. But the big message is, we really want the surgeons, whether it be an ENT, dentist, or oral surgeon, understanding that in the ideal world, we want that functional assessment and pre-op first, because that's what's going to make for the much better outcome in terms of aftercare and neuromuscular re-education. They're both as important.
Such a great place to end this conversation before we start taking questions, because it always comes down to function. And a few weeks ago, I had Dr. Baxter on the Monday Night with Coach Mel as well. And I now have that video on my YouTube channel too for everyone.